this is the introduction to the early psychosis intake process. These are our learning objectives for the day. Hopefully by the end of today, you will understand the stages of referral through treatment in the early psychosis program, learn the purpose of the eligibility assessment, also known as the intake, and learn the components of that assessment. And hopefully this image is familiar to you. It is the UC Davis EDAPT Coordinated Specialty Care model and all of the elements. And this is the work that we do with clients and families once they have joined the clinic. Today, we're going to talk about how we get clients and families into this coordinated specialty care model. And so I'm going to be reviewing what happens from referral through to treatment and then graduation. And then we're going to focus a lot on the intake assessment process. So the first thing that happens is clients are referred to your program. These referrals are typically prompted by outreach presentations that are given to the community by your program. So you might go out and provide outreach presentations or educational events to local community mental health providers, your local mental health urgent care or crisis centers, perhaps your local EDs, as well as your local school districts. These outreaches are typically conducted by program directors or supervisors or other trained folks. Program coordinators, clinic coordinators can also do this as well with the right training. And really just, it's anybody who's trained to do it, who's comfortable with the model and familiar with the program and has the time to do this. And it can, an outreach essentially can range from anywhere from 15 minutes of sort of just quickly covering your referral and eligibility process, all the way up to an hour or so of providing more educational content about psychosis and how to identify it. Once that referral comes in, what we do is we schedule an initial phone screen assessment with the client and a family member or collateral. This is typically conducted by a clinic coordinator, somebody who is sort of managing intake paperwork flow or doing the scheduling or coordinating appointments. That sort of role is also typically the person doing the phone screen, although anybody who's trained to do it can do it. In our clinic, some of our clinicians do it, some of our program coordinators do it, and some of our folks who are in more of a administrative assistant style role can do it as well. And the purpose of this phone screen is it takes about an hour, and you gather information about demographics, social and role functioning, mental health treatment history, developmental history, mood, suicidality, substance use, and a few key questions from this assessment that we're calling the SIPS. And I'm going to tell you what the SIPS is a little bit later. And the purpose of this phone screen is to very quickly screen out folks who are clearly ineligible. So folks who clearly don't meet your age criteria. If you only serve ages 12 to 35 and somebody aged 10 is referred to you, you can screen them out either at the referral or the intake phone screen. Or if somebody has had a psychotic disorder diagnosis for 10 years and you only see folks who have had their first episode within the last 2 years, you're going to screen that out at the phone screen. And so the phone screen offers this sort of more rapid ruling in and ruling out of folks who may or may not be eligible for services. And then for those folks who do appear to be eligible and should be moved forward to the next stage of the process, the phone screen also gives the intake assessor a lot of information that can guide them in the intake so that they can be more efficient with their time. So the phone screen is a very useful tool. Once a client has completed the phone screen and it appears that they might be eligible for services, they're then moved on to what we call the eligibility assessment or the intake. So we typically just use the word intake in our clinic, but I want to tie that to this term eligibility assessment because that's really what you're doing. You are determining if the client is eligible for services at your clinic. This eligibility assessment is typically conducted by a trained clinician. It could be conducted by any master's level person in your clinic who has a good background in psychopathology and assessment training. In our clinics, the clinicians do it. I have worked in other clinics where case managers with appropriate training background and support have also been doing intake assessments. So that's a conversation to have as part of your consultation with the TTA. Who should be doing this? Who can do it? Who's the most appropriate? The assessment takes about 3 to 4 hours of client and collateral facing time, as well as about 3 to 4 hours of record review, kind of collating everything together and writing up that assessment. So we dedicate a full day to this in our clinic, and there's a lot of different ways that you can slice and dice this. And again, that can be a conversation that happens as part of your consultation with the TTA team. And the eligibility assessment includes assessment of psychosocial functioning, psychosis symptoms, mood, substance use, and trauma, as well as demographics and other relevant background history that you'll need for evaluation. Once that eligibility assessment is done, we then do an assessment feedback. Now, everybody who comes through this process, regardless of whether they're going to end up receiving services in your clinic or not, receive this assessment feedback. It's a very important part of the process. If the person is eligible for services, we provide a summary of the assessment results. We invite them to the clinic. We sort of do a bit of a pitch why we think our clinic is going to be the right fit for them. And then that transitions into what we call the welcome session, which is really an overview of the clinic and its services, a little bit of initial psychoeducation, some orientation to the various team members, and kind of getting them started with the team. If the person is not eligible, we still provide a summary of the assessment results, and we then provide a clear justification of why they're not eligible for our clinic, and then we provide our treatment recommendations. Where do we think they would be best served? What do we think is most appropriate? And then we walk with them and do that linkage to services. So it's possible that for folks who are ineligible, if they're not already linked, so they're coming to you and you're the first linkage for them, you still may hold them for a little bit, doing sort of case management while you link them to the right place, even if your clinic is not the right place for them. If they're already linked for services, you would refer them back to the services that referred them to you. You provide the necessary records of information and other recommendations, and then the client could either remain with that current provider or move on to the appropriate place. For the eligible folks, once they've done that assessment, feedback, and welcome session, they're then going to go into the time-limited treatment, which is on average about 2 years. Sometimes it stretches up to 3, depending on the case and the needs. And that's the bulk of the work, right? We're using the coordinated specialty care model to implement multiple evidence-based treatments to meet the individual client and family needs and support their recovery goals. We're conducting regular outcomes assessments. We're doing it every 6 months to evaluate progress towards those goals and make treatment adjustments as necessary. And we begin, very intentionally, we begin sort of discharge planning and graduation preparation around the 18-month mark, so that the client and the family have time to adjust. You've got time to have conversations about what the appropriate discharge options are for that client and family, and so that you can start that graduation process, celebrating their successes, helping them generalize their skills, and then helping them graduate from the program and out into the community. So that's the process through the clinic. So for the rest of today's discussion, I'm going to be focusing in on the eligibility assessment or the intake. And I'm going to be talking about purpose and components and orienting you all to how we train folks in those elements. So what is the eligibility assessment and why do we do it? And there's really 2 things that I think are important to understand about the purpose of this assessment. Purpose number 1 is that you're doing this assessment to determine if the client is eligible for early psychosis services. So at a very basic level, you're really asking through a multitude of validated tools, does this person meet clinic criteria? Now, once you have an answer to that question, you need to answer a second and equally important question. Is the client appropriate for your clinic? The answer here, the question you're trying to answer here is, are clinic services appropriate for client and family at this time? And I'm going to give you a few tools, a few questions that we can ask ourselves as we're reviewing assessment results to help us answer this eligibility and appropriateness question for each client. So in the first case, we're trying to determine if the client is eligible for services. So at a very basic level, we're asking things like, is the client within an age range defined by your clinic? That's going to be determined probably at referral or phone screen. It would be unusual you don't want somebody to get to the intake step and us not to have caught that, right? So that's why we have these multiple points of evaluation. Then you want to ask this question, is the client experiencing either attenuated psychosis symptoms, so those early signs that are causing some distress and impairment but aren't necessarily considered psychotic level, or are they experiencing psychotic level symptoms? And you're going to determine this through a combination of the initial information gathered at phone screen and then the follow-up work that's done at the intake. For those clients who have psychotic level symptoms, present, for example, the client has already had a psychotic episode or is currently having one, you then want to determine if the onset of those psychotic level symptoms within the past 2 years, which is a typical eligibility criteria for early psychosis clinics, right, is that we serve folks within 2 years of their first psychotic level symptoms. Now, there is some variation in this number of years across the United States. And if your clinic is considering a variation on that, let's talk about it as part of our program-to-program consultation. And then the final question that you're asking is, are the psychotic symptoms independent of substance use? So what we're trying to rule out here is a true substance-induced psychosis, because if it is, the treatment recommendations are going to be different, and they might not be eligible for services with us. I have put a little asterisk here at the bottom of the slide. I want to be very clear that right now, as we understand it, that substance-induced psychotic symptoms do typically resolve within less than a month of ceasing all substance use. So anything longer than that is going to indicate that it's not substance-induced. And this is going to be a question that's going to pop up a lot, because we're going to get a lot of young folks coming through your program who are using marijuana, and there appears to be a link between their marijuana use and their psychotic symptoms, but the psychotic symptoms will continue beyond marijuana use cessation. So even though in the timeline, it seems like the marijuana has instigated the psychotic symptoms, because they have not remitted with cessation of use, we would not necessarily determine that as substance-induced. And we might conceptualize the marijuana use as more of that stressor that combined with the vulnerability that that person already had and led to the expression and manifestation of psychosis. So there's going to be some nuanced discussions around substance use, and that is part of the reason why we do such extensive assessment training. So those are our 4 main eligibility questions. Now, your program may have additional eligibility criteria. So not all programs serve clinical high risk, not all programs serve certain diagnoses. And that's going to be something that we will talk about again as part of your discussions with the TTA team. Once you've determined eligibility, you then need to answer this question of, are they appropriate? Are the services that your clinic is able to provide appropriate for that client and family right now? First, does the client have an intellectual disability that might require alternate approaches? So for example, if the IQ, demonstrated IQ to be less than 70, this might require a cognitive assessment, or you might have to review school records, et cetera, to determine this. Does the client have comorbid challenges that ought to be addressed first and in a different setting than what your clinic is capable of? So if somebody's coming in, maybe they are eligible, maybe they have a primary psychotic disorder, but they also have very severe substance use that needs to be handled first, in which case you might refer to a substance use program first and then have them return to you. Same for folks who come in who may have both psychosis and an autism spectrum disorder diagnosis, and perhaps through your evaluation you determine that the autism spectrum disorder challenges are more primary, are causing more difficulties, and the client would be better served in an ASD setting. And so again, is your program appropriate for that client and family right now? Another question that's really important to ask ourselves is, does the client need a higher level of care than our program can provide? So might they need wrap services or FSP, in-home, in community, maybe group homework? And if that's the case, then you're going to want to refer them and get them linked to that higher level of care, and determine what sort of requirements would, what kind of recovery goals would they need to meet in order for them to be able to step down to your program. And then the final question that I think is really important to ask in terms of whether your services are appropriate for the client is whether the client and the family are really willing to engage in the treatment model. Now, this question does get us into a bit of a gray area, because sometimes clients are a bit reticent at the beginning, but then with appropriate motivational interviewing and engagement and working with the client and family to remove barriers, they really do engage. And so this is not a black and white question. This is not a yes or no question. You sort of have to have some motivational interviewing, determining stage of change, determining barriers, doing a bit of a needs assessment with the client and family, so that as a clinical team, you can review the case and say, okay, the client is struggling to engage and they want to, and if we support them in these barriers, then they'll be engaged with the model. And that's really different from the client is clearly saying that they do not want to participate in this clinic. They don't want to do anything other than take medications. So on the one hand, you might bring in a client that could have some struggles engaging, but ultimately will do very well. But you might not bring in a client who is saying, I don't want to go to therapy. I don't want to go to groups. I don't care about supported education and employment. I just want to see my psychiatrist every other month and get my meds. So for that person who just wants to see their psychiatrist, and doesn't seem to be movable on that, and motivational interviewing is not helping, then the coordinated specialty care program is not the right fit for them right now. They can always come back, and you would provide them education on what their timeline is for coming back. But it's not a good use of your limited resources to bring folks like that into the clinic if right now it's not the time for them to engage in coordinated specialty care. So now that we've talked about this idea of determining eligibility and determining appropriateness, let's talk about what happens at the assessment and how we're going to do that. So as I said before, the clinician is going to conduct a 3 to 4 hour long eligibility assessment with the client and a collateral member. So it could be a family member or a loved one or someone who is informed on the client's experience and willing and able to attend. You're going to use validated assessment tools to evaluate psychosocial functioning, psychosis, mood, trauma, and substance use. You're going to review records and gather information from collateral and other providers, and then you're going to use all of that information to inform a differential diagnosis and to determine eligibility for services and any treatment recommendations. And the tools that we use at the intake are as follows. So we evaluate psychosocial functioning using 2 tools called the GFS and GFR. And don't worry, I will tell you what those letters stand for. And what these 2 assessments do is they evaluate the client's role functioning, so how they're doing in school or work or as a homemaker, depending on what is appropriate for that person. And they also evaluate the client's social functioning, so what is the quantity and quality of their social relationships. We assess suicide risk using the CSSRS, that's the Columbia Suicide Severity Rating Scale. This assesses current and past suicidal ideation behavior. And based on that assessment, you're going to implement appropriate risk management, for example, a safety plan at intake, because we want to make sure that we have that early intervention. We evaluate psychosis symptoms using the SIPS. And this is a tool that evaluates the presence, severity, and onset of psychosis symptoms, which are all bits of information that you're going to need to know to determine eligibility. We then evaluate mood symptoms using the SCID, which is a tool that assesses all of the DSM-5 diagnoses. And we use it to assess for any current or past mood episodes like depression or mania, and also the overlap or lack thereof with any psychosis symptoms that the person is having, so that we can determine what the primary diagnosis is. So that's where your differential come in, right? Is it a primary mood disorder with psychotic features, or is it a primary psychotic disorder with mood features? And that's where using these tools, the SIPS and the SCID, can be really helpful. We also evaluate trauma symptoms using trauma screening questionnaires And then based on the responses to those screening questionnaires, we may do further evaluation using the trauma module in the SCID, which is, as I said, a semi-structured interview for evaluating DSM disorders. So if comorbid trauma symptoms are present, we're really trying to ask this question, are they primary or secondary? And that's going to inform treatment approach and treatment recommendations. And then finally, you're going to evaluate substance use using the SCID as well. And really, at this point, you're trying to rule out substance-induced psychosis or any substance use comorbidities that might impact treatment engagement or treatment response. So those are the validated assessment tools that we use and what they're assessing. I'm going to take a little dive into each of them just so that you're oriented to what each of them are. And then I'm going to talk about how we train you on them. So the GFS and the GFR are the Global Functioning Social Scale and the Global Functioning Role Scale, respectively. They are semi-structured, clinician-rated interviews for evaluating psychosocial functioning. And when I say semi-structured, what I mean is that there is a list of questions that can guide you and that are helpful for structuring this evaluation, but you can also use those questions flexibly. If you already know the answer to some of them, you don't need to, you can skip them. If you need to ask follow-up questions, you can do that. So the semi-structure, it gives you a framework, but it gives you some room to play. It assesses social and role functioning separately, and you give each one a score on a 10-point scale. And I would say on average, it takes about 20 minutes to administer the two of them together. Could be a little less, could be a little more, depending on how verbose the client is or how much detail they have. And I will say that we do a little bit of this on the phone screen as well as at intake. So typically you're going to be using the answers on the phone screen to help guide you in filling in any gaps at the intake. So just a little bit more detail here about our Global Functioning Social Scale. So it assesses aspects of social functioning, including peer relationships, both quantity and quality, peer conflict, age-appropriate intimate relationships, and involvement with family. And there really is an emphasis on social contacts and interactions outside of the family, unless those are the only contacts or it's culturally normative or age appropriate. So for your younger clients, if their primary social contacts are within the family, that makes more sense. Whereas sort of as you get older and you're in the kind of young adulthood phase, we would typically anticipate folks' social contacts to be have more interactions outside of the family. The Global Functioning Role Scale, a little bit more information here, assesses aspects of role functioning, including the type of age-appropriate role. So are they in school or are they in work or are they a homemaker? The quality of that role, so how demanding is that role and how challenging. The level of support that they have in that role to succeed. So, for example, if the role is school, what is the school environment that they're in? What level of supports do they have, IEP, 504, etc. And then using all of that, what kind of performance, how well are they doing in that role that they have based on appraisals or feedback or grades or so on and so forth. The emphasis is on age-appropriate accomplishments and the level of independence in that role. So how successful are they and what level of support do they need to meet that success? And as you can tell, the very first thing you would do is determine what that primary role is. So that's our social and role scale measures, the GFS and the GFR. And that's actually something that we're going to be learning about this week. And I will be orienting you to that training at the end of today's discussion. The CSSRS, as I've already mentioned, is the Columbia Suicide Severity Rating Scale. It is considered the gold standard for assessing suicidal thought and behaviors in adolescents and young adults and can actually be used for all ages. It's also a semi-structured interview with this sort of flexible format and evaluates ideation and behaviors separately and takes anywhere from 5 to 15 minutes to administer, depending on the extent of the person's history. So we've covered the GFS and GFR, we've covered the CSSRS. Let's talk about what the SIPS is. So the SIPS is the Structured Interview for Psychosis Risk Syndrome. This is I would also say this is semi-structured in that there is room to play, but you also have these very clear questions and follow-ups that you need to ask. And it's been designed to be used with teen and young adults and their caregivers or other relevant collaterals, and provides a detailed evaluation of the nature and severity of psychosis symptoms, all the way from attenuated experiences up through psychotic level experiences. And what we do is we combine the information that we get from the SIP with collateral information from treatment providers, significant others, referral sources, and so on, and use that to determine the presence of psychotic symptoms, and if they're present, at what severity are they. When the SIPS is administered in full, it takes 2 to 3 hours, but never fear. We typically only administer portions of the SIPS at the eligibility assessment. In fact, we just focus on positive symptoms only, because that's the stuff that we need to know to determine eligibility. And that takes about an hour. It can be a little less, and it can be a little more, again, depending on the complexity of the client's history, how verbose they are, and the extent to which you need to ask follow-up questions. And again, this is where the phone screen can be really, really helpful, because we do ask some of these key questions from the SIPs about positive symptoms on the phone screen, and then the clinician who's going into the intake can read those responses on the phone screen and then make some really strategic choices about how to follow up at the intake. So let's move on to the SCID. So the SCID is a structured clinical interview for DSM-5 disorders. It was actually developed in conjunction with DSM-5. It's also a semi-structured interview for the differential diagnosis of DSM-5 disorders. So you could use the SCID to evaluate anxiety disorders, obsessive compulsive disorders, substance use disorders, trauma, mood disorders, psychotic disorders, other like stressor related disorders. There's a whole host of modules in the SCID that you can use. And it has this modular structure that allows you to sort of construct the interview that you need to evaluate the things that are most important to you at your intake. And it has this skip out style, which means that if somebody says no to like really key criteria for a disorder, you don't need to continue asking questions about that disorder. And that allows you to kind of flexibly adjust the interview based on the client's responses to screening questions and so on and so forth. So the SCID is this very broad tool, but it's structured in such a way that you can really narrow things down, focus in on what you want to assess, and really be efficient. And what we do in our eligibility assessment is we use the modules in the SCID that assess mood episodes, so depression and mania, etc., that assess trauma history and assess substance use. We use the SIPs for our assessment of psychosis. So you use the SIPs for psychosis and the SCID for mood, trauma, and substance. You put it all together and come up with your differential diagnosis. In the format that we use it, I would say it can take anywhere from under an hour up to 2 hours, depending on the client's presentation and complexity of their history. So that's the SCID. Finally, we recommend using trauma screening questionnaires at eligibility assessment or your intake, and then using those responses to guide further assessment of trauma symptoms using the SCID trauma module. So the 2 screening questionnaires that we recommend are the PCL for adults. So this is the PTSD symptom checklist. And we actually recommend using it with the life events checklist criterion. And we will share these with you as part of training. And then for under 18s, so folks under 18, we recommend the CATS, the Child and Adolescent Trauma Screen. I would say that completing one of these takes anywhere from 3 minutes to 10 minutes. For the client. So the client is the one that responds. And then in the case of using the CATS with minors, the parent will also fill one out as well. And you'll use the 2 responses to inform your follow-ups. And then if based on the responses to those trauma screening questionnaires, it seems like trauma is present and you need more information for your eligibility assessment, then you might choose to use the trauma module of the SCID, which can take up to kind of 15 to 20 minutes of administration time. I will say that we do not always get to the trauma module of the SCID in our intakes because we might run out of time. And that's okay, because remember, the purpose of our intake is to determine eligibility. not to do this sort of comprehensive diagnostic evaluation, right? That's not what we're going to do. We don't have the time to do that. At this first assessment, we are trying to determine eligibility and appropriateness only. And if they are eligible and appropriate, you can do further assessment as part of your ongoing treatment, and you can really flesh out that comprehensive evaluation. But really at the intake, we want to know, do they have psychosis? Do they qualify for services? And are they eligible and appropriate? So that's the whirlwind tour of the elements of the intake. And I'm just going to go back to this slide to remind us, right? So we assess psychosocial functioning with the GFS and GFR, which I've now oriented you to. We assess suicide risk using the CSSRS. We evaluate psychosis symptoms using the SIPS. We evaluate mood symptoms using the SCID, trauma symptoms using our screening questionnaires and the SCID if indicated, and substance use using the SCID. And I will say that there is a substance use screener that can make this process very quick. So if the person and their records and collateral indicate that they've never used substances, you're going to skip this entirely. You're not going to evaluate it. So how do we learn how to do the eligibility assessment? What's the training plan for getting comfortable with this? So at first, what we do is we teach you each assessment tool individually. So we orient you to the purpose and the structure of the tool, and then we provide some way of practicing using the tool and learning how to score it reliably. So that's the first step, is we're going to teach you each assessment tool individually as they were intended to be used in isolation. But then we're going to learn how to use the phone screen to inform your assessment approach. So the phone screen is going to provide you a lot of really useful information. And just by reading that, you'll start to build your differential diagnostic list, right? So if some bit of information comes up on the phone screen, like client has been using marijuana for 6 months and symptoms started at the same time, well, now you know that at your clinical intake, you're going to want to rule out substance-induced psychosis, because that's a clear eligibility criteria. Or the phone screen might tell you that client has been experiencing hearing voices that other people don't hear, or when other people aren't around, for about 3 years. And you're going to want to determine at the intake, at what point in those 3 years did those experiences of hearing voices reach a psychotic level, if ever. And that onset of the psychotic level is going to start that treatment clock, right? So if your eligibility for your program is onset of psychotic level symptoms in the past 2 years, well, we're going to want to determine at what point did this person's auditory hallucinations reach a psychotic level, and was it within the past 2 years? So that phone screen is really going to flag some important things for you and help you make your intake assessment as efficient as possible, right? You know, if the phone screen clearly says this person has never had substance use, this person has never had trauma, well, then you know you don't need to spend time on that in your intake, and you're going to focus on the other stuff. So we're going to teach you how to do that and teach you how to really use that to guide your approach. Then we're going to work with you to learn how to integrate the assessment tools together into one intake, right? So there's like 6 or 7 different tools here, and the skill is not only knowing the tools themselves, but also how do you put them together? What are some recommended order of administration? And how might you make flexible decisions in response to the client's needs or presentation? You know, maybe you typically start with one, but then the client comes in and presents differently. We're going to teach you how to make some decisions in the room about what you may or may not start from, or focus in on, or skip out. And then we're also going to have conversations with you about how to integrate the assessment tools with the clinic required paperwork that already exists for you. So you're going to work with the TTA team on a program by program level, and we're going to understand your intake assessment, the existing intake assessment workflow that your county might require, particular bits of paperwork that your county or your institution is asking you for. And we'll problem solve with you on how to integrate all these tools in such a manner that it feels like an efficient and sort of smooth flow when you end up doing the assessment. And that's going to, that's going to look a little different depending on the program. And then finally, we're going to help you with practice. Our recommendation in general is that folks observe at least one, if not two, intakes by a trained person. Then we recommend co-lead an intake with a trained person if they're co-pilot, sort of a glamorous assistant. And we recommend at least co-leading two, and then going on and conducting intakes, sort of flying solo, we call it. But I want to say that in the model, in the coordinated specialty care model, you're never really flying solo. You're always doing it as part of the team. And a really key part of the model and the training is having regular assessment supervision as part of your treatment team's meetings. I can tell you what we do in our program and what our county partner programs that are already up and running do is we have a weekly assessment supervision meeting, and we review the intakes from the prior week. At that meeting, we answer sort of complicated cases questions, we do differential diagnoses together, we discuss the ratings, and develop a kind of follow-up action plan. If you are in a clinic that is brand new and doesn't have any trained folks yet, don't worry. We will work with you to figure out how best to support you in those observations or supporting you in co-leading, and just creating a very supported, scaffolded approach to doing these assessments. And that'll just be a conversation that we'll have with you as part of that kind of one-to-one, and when I say one-to-one, I mean like PTA to program meetings where we really get a good understanding of your program's individual needs and scenario, so that we can flexibly adapt this supported practice to fit that.